Yeah, we'll start now.
Yes, madam, we are live. You can start.
Yeah, good morning, everyone. I wish everyone a happy Dasara. And today's topic is extremely important as clinicians to know how to grade embryos. This is to make sure that the IVF clinics have good pregnancy rates, but at the same time reduce the chances of multiple pregnancies. As we all know how tough it is to deal with multiple pregnancies, and also the success rate of IVF clinics is now extremely important because of the competitive field that it is in. So if we select that one good embryo and transfer it, so the chances of pregnancy, we expect it to be the best that we will be giving the patient without at the same time increasing the risk of multiple pregnancies. So over to you, sir, for your demonstration.
Hi, Shilpa madam, and hello to everyone. See, I am talking to all of you from inside of the laboratory, and it is important to understand that whenever we are trying to talk of embryo grading, okay, the embryo grading is to be performed on the operative microscope and not on the stereo zoom microscope. So that is a very important take-home point. Operative microscope has phenomenal magnification. There is no question, there is no doubt in that entire fact. So what typically happens is, this is the lowest grade of magnification. As you can see, the lowest grade of magnification on an operative microscope comes to approximately 4 times. I think, I don't know if it is correctly going to be visible, but you have various focal lengths which are present here. So I'm going to be changing the focal lengths and I will be going to the standard magnification, which is approximately 20 times. Okay. And I want to increase whenever, so I've increased it and I've gone to the magnification at the time of laser hatching. Now, laser hatching is the one of the highest magnification which is possible, and I have gone to that. So when I go to that, I will just show you the screen now. See, whenever we are assessing the embryo, so this is the first thing which we are going to see in your culture plate. So I will just show you how this entire picture actually transforms. Okay, so let's go to the lowest grade of magnification. Now this is the lowest grade of magnification, and now on your screen you can see multiple embryos. Correct, Shilpa madam? I'm audible, right?
Yes.
Yeah. So now this is the multiple embryos. This is not the magnification on which as a clinician you should be able to choose. Okay. As a clinician, see, we may be very good embryologist and we may be very good clinician simultaneously. But this is a lecture which is meant for predominantly who have a busy IVF practice and they don't get enough time due to their work routines to enter the IVF laboratory very frequently. So what we normally people will rely on, they will rely on their biologist or their embryologist to tell you if it is a good grade embryo or if it is a bad grade embryo. So I've just increased the magnification slightly. Okay. I have increased the magnification even more slightly now. All right. And now I'm going to the final magnification. And this is the magnification on which ideally embryo assessment should be done. So you can see here, this is an excellent blastocyst embryo. Now, why did I call this blastocyst embryo excellent? See, remember, this embryo has to develop this cavity inside. Can you see this? Now, this cavity is the blastocele. This cavity develops from all the outer cells. These are called as OCMs or outer cell mass. And this is the ICM, which is inner cell mass. You can see a compact layer of cells which are at one end. Okay, that is the inner cell mass. It is the inner cell mass which gives rise to the formation of an embryo. Now, there is an equation which people say, okay, I understand this is a blastocyst, but how do I call this is a good blastocyst? All right. See, the blastocyst grading is something which is characteristically mentioned in many textbooks, but for general and practical purposes, let's just go into the grading, which as a clinician we should know. Okay. So there is a blastocyst, there is an early blastocyst, and there is an expanded blastocyst. Just look into that. Okay. Now, how do you say? So I would label this only as a blastocyst and not as an expanded blastocyst. The reason why I am saying is just note down this tip as clinical point. Okay. Can you see the width of this cell? The width of this cell is equal to the width of the zona. This is the zona pellucida. Can you see the zona pellucida which is surrounding? The width of the cell on the trophectoderm is equal to the width of the zona pellucida. So this is simply a blastocyst. This is not an expanded blastocyst. All right. You have an excellent cavity which has appeared inside, and this cavity is occupying more than 70% of the volume of the blastocyst. All right. So that means it is a blastocyst. In an expanded blastocyst, it will occupy close to 80 to 90%. All right. And in an early blastocyst, it will be less than 50%. Okay. And this is the inner cell mass, which is present on one side. So whenever you have an inner cell mass, yes, this is a good blastocyst. For clinical purposes and for clinicians' purposes, let your embryologist go and grade it further. But as a doctor, this is something which you need to tell to your patient. Okay. So I will again zoom out and I will try and hunt in this plate for an early blastocyst. See, I just mentioned to you about an early blastocyst, and here we go. This is an early blastocyst. Very simple to understand from what I just explained to you. Okay, can you see the cavity is just about to appear inside, right? The cavity is just about to appear. This is an early blastocyst. The width of the cell is more than the width of the zona, and the inner cell mass is already on one side. Okay, so this is an early blastocyst. Very simple. Now you will understand. The minute you see 20 embryos like this, all of you will become champions by the end of the day, on the day of Dashera, to start grading these embryos and putting them into clinical practice. Okay. Do we have an expanded blastocyst in this plate? So I'm quickly scrolling through the plate and I don't see an expanded blastocyst in this plate at the moment. दूसरा plate है अपने पास में? Okay, day 3 का बाद में plates लेके आओ. Okay, so an expanded blastocyst, all we need to keep in mind is going to be further more than even this one. Okay. It is going to be further enhanced than even this embryo. You can see this is one of the most expanded blastocysts in this plate. But see, the trophectoderm cells and the zona are almost the same thickness. So when the zona gets very, very thinned out, it is an expanded blastocyst. And that is an expanded blastocyst which occurs prior. Okay, this is an expanded blastocyst which will occur prior to getting hatched. Okay, so I want to see some day 3 cells as well, day 3 embryos as well. And I also want to see just fertilized embryos. कल का इक्सी वाले कोई भी एक प्लेट दिखा दो मेरे को. टाइम लैप्स पे कुछ है? Okay, fine. Thank you so much. So these the day 5 which we showed will obviously go for vitrification now. Okay, because it is a freeze-all cycle. All right. Now we move on to another plate, and this is a plate where we have embryos. Again, you can see these are day 3 embryos. So for clinical purposes, do not end up grading anything as day 3. It is going to be ideal if you put them into time order at day 3. Okay. Okay. We have a good plate here, and we will have very good embryos which are going to be seen. So one we saw already is the blastocyst, because many for it will blastocyst. Why do I call embryo to be excellent day 3 embryos? Can you see this embryo which is appeared in front of you? In all the planes of the embryo, okay, apart from this one small plane, can you see a small fragmentation here? This fragmentation is less than 5% of the embryo. Okay, this seems to be a very good day 3 embryo. But remember, on your day 3, try to give hours. Is it 68 hours? Is it 70 hours? Is it 75 hours? Whatever. Okay. Just in case you really want to enhance your outcomes. Okay. Otherwise, you can just standardly label this as day 3. And when you see this is a good day 3 embryo. Why? Because all the blastomeres are equal in size. All the blastomeres are equal in size. Fragmentation is less than 5% only at one corner. This fragmentation typically occurs due to poor quality of oocyte. Okay. Just remember that. This is an unfertilized oocyte, so there is nothing which we can grade in this. Why I am calling it unfertilized is because you can see the polar body, and the polar body is as it is. So despite injection, the polar body has not got dissolved. Okay. This is yet another excellent embryo. You can see all the blastomeres are equal in size. Very, very little fragmentation inside the embryo. So this is an excellent embryo on day 3. Okay. But simultaneously, you have a poor embryo also. See, this is very unequal embryo. Unequal blastomeres. This blastomere is bigger than this blastomere is bigger than this one. Okay. And simultaneously, if I change the plane, there is so much fragmentation. Fragmentation is more than 20%. This is a very poor quality embryo. This will not progress further. Okay. Same thing here. See, poor quality embryo, lot of fragmentation, unequal blastomeres. All you have to remember as clinicians, okay, is that are the blastomeres equal in size, and is the fragmentation less than 5%? If the fragmentation is more and the blastomeres are unequal on day 3, it indicates a very poor quality embryo. Okay. Same thing here. This is a 6-cell embryo. To be honest with you, this is a 6-cell embryo, no fragmentation, but it is a poor quality embryo because by now this embryo should have had 8 to 9 cells. It is at 6 cells, so ये थोड़ा slow है, and whenever embryo is very slow, or whenever the embryo is very fast, that is called bad, because that indicates aneuploidy in the embryo. जो correct time पे बढ़ता है, the embryo which grows on the right intervals, okay, is the embryo which is considered to be normal, okay, and has a higher possibility of developing any form of euploidy. All right. किसी के भी embryo पढ़े हैं time lapse में? किसी का एक भी प्लेट नहीं है? किसी और का वीडियो मिलेगा, वीडियो प्ले करो. So guys, I just want to show this entire development to you on how the way in which this development occurs on a time lapse. So this is one patient's embryo, and this is a time lapse imaging system to grade the embryos. Obviously, remember one thing, guys. Whenever you are doing a time lapse, no, please try and understand that it is not going to be something on time lapse where it is going to enhance your outcomes. कोई भी एक embryo को play करोगे? Yeah, so we are playing all the embryos, and you will be able to see. Pause करो बेटा इधर. अच्छा, इसके आगे के फ्रेम में जाओ. Go in the front. स्टार्टिंग से प्ले करो, चलेगा. Yeah, you can see here. So this is the embryo. Now ICSI has occurred, and you will see the formation of 2PN. Can you see the two polar bodies which have formed? The two polar bodies disappear, and once they disappear, they will start having division. At the end, once the division occurs, you will see that there is some fragmentation appearing inside this embryo. Okay, and at approximately day 3 stage, here we are about to be on day 3 stage. It is developed 8-cell embryo, but it is severely fragmented. Despite all this has gone into a morula stage. Okay, and you will see that from the stage of morula, see how beautifully the embryo would just autocorrect, and it has given rise to an excellent blastocyst. So that now this is the most important take home point. Okay, the reason why I showed to all of you this entire thing is because this is a very, very important take home point in an embryology class for people, that no matter how beautifully you end up grading these embryos, no matter what you think is the stage of an embryo at day 3, and you think it has got fragmentation, this fragmented embryo can still become a blastocyst. If you have graded an embryo and you have told that this embryo is an excellent day 5 embryo, expanded blastocyst, despite that grading, you are not going to be able to tell the patient that don't worry, I have graded it, this is going to give you a 100% success rate. There is nothing like that. As a result of this, it is very important for clinicians to remember that embryo transfer of approximately 3 day 3 embryos is going to give you equivalent outcomes of one blastocyst which is completely expanded. Okay. As a result of which, many a times people have these debates and keep on calling me, at least because I have been a traveling embryologist to many places, that Jai, for this patient, I have just day 3 embryos and I want to transfer day 3. Shall I transfer day 3 or shall I wait till blastocyst? Okay. So the clinical understanding out of this is, if you have 3 excellent day 3 embryos, which we have graded as equal blastomeres, less than 5% fragmentation, the possibility that out of these 3, one will develop into a good blastocyst is very high, and it will give you excellent blastulation rates and equivalent implantation rates to a single expanded blastocyst embryo. And simultaneously, please note one more thing. Irrespective of putting a very good expanded blastocyst in the uterine cavity, okay, it does not guarantee the success rate of your IVF cycle, because this is your morphological grading. This is the grading of my eye. The video which I showed you on time lapse, if I would have graded that embryo on day 3, I would have told that no, it is a poor quality embryo. It has more fragmentation, around 20% of fragmentation, and the possibility that it will develop a blastocyst is not going to be very high. But as you saw in the time lapse, the reason why we showed it to you is because despite that morphological grading, it formed an excellent blastocyst. It formed an excellent expanded blastocyst. Okay. So please, embryology is one subject where you really will have to see and you will experience miracles of nature daily on a day-to-day basis. You will have embryos which you will grade as poor quality embryos, and they will give rise to implantation rates, and patients will have twins. You will have consistently expanded blastocyst embryos which are not giving an implantation either. Okay. So with this, I finished the basics of grading. Because from clinical perspective, it is important that if you want to assess your embryo prior to embryo transfer, then either it is going to be a day 3 embryo or it is going to be a day 5 embryo. Okay. The best way to assess is assessing on an operative microscope. And once it is once you have assessed it on an operative microscope, you will be much more confident to go and tell to your patient. This is not an embryology class. I can really go into fantastic details of day 3, day 4, and day 5 embryos each. And I can probably speak on each embryo for close to 3 to 4 hours on how we are supposed to micrograde these embryos. Okay. But that is not the purpose of this class. This purpose is to practically educate all our colleagues so that next time they go inside their IVF laboratory, they and their biologist or their embryologist are on the same page when it comes to counseling the patients about the most appropriate success rates for that particular embryo transfer. So thank you so much. And I'll push the mic to Shilpa, madam.
Yeah. So the embryo that you showed on the time lapse, which recovered to a blastocyst. So if you were to tell the patient about the success rate, okay, would you tell them that it is a recovered blastocyst from having so many fragments, or you would just put it?
So honestly speaking, the newer understanding, when we take the session on PGTA, no madam, I'm going to describe what is the newer understanding in embryos. And that is that you should only grade the embryo once. You should not have multiple checkpoints for grading the embryo. Understanding? And that is considered to be something called as the final embryo grade. So what is the final embryo grade? The embryo grade at the time of embryo transfer. Okay. This is provided you are not doing PGTA. That's a different topic. See, if you do PGTA, then you are going to say that a poor embryo becomes a euploid embryo. Correct? But it is also going to be possible that a mosaic embryo is going to autocorrect. The reason being, what you saw right now, that fragmentation getting absorbed, is a beautiful example of how nature autocorrects itself. As a result of which, we commonly tell in non-commercial embryology groups, okay, that PGTA, publicizing PGTA or saying that PGTA should be done for all patients, like how many commercial IVF clinics would do, is a pure commercial gimmick. Okay. Otherwise, a mosaic embryo can autocorrect and become an euploid embryo. All right. A euploid embryo can distract and become an aneuploid embryo. And an aneuploid embryo, which does not have high aneuploidy, can also autocorrect and give rise to fantastic live births. And this has been published. It is not my talks. It has been published. As a result of which, I showed that time lapse.
Okay, so with regard to as a clinician, since this is for clinicians, so with the use of REC-FSH and HMG,
it makes no difference. The only difference which you are going to find between REC-FSH stimulation and HP-HMG stimulation is the way in which the ooplasm looks. Okay. With HP-HMG stimulation, your ooplasm is going to be slightly more granular. That is because of slightly higher androgen content inside the follicle fluid. Okay, slightly higher LH content inside the follicle fluid will make the ooplasm slightly more granular. If you look at REC-FSH stimulation, pure REC-FSH stimulation, your ooplasm will appear like beautiful, like a supermodel ooplasm. But that does not really mean that ooplasm has the best possible meiosis, because again, that is a morphological grading of that ooplasm on a single plane. Okay, it is not a 3D grading of the ooplasm.
Okay, so usually when do you do day 3 transfers and when do you do, or majority you do only blast transfers?
So it now, again, I would like to answer this in a manner where you are supposed to define your lab standards. See, if in case you want to put only blastocyst embryos, I'm sure you can integrate your laboratory in such a manner that you are going to optimize everything for a blastocyst, right? And only when the blastocyst is formed, you will transfer. Till the blastocyst is not formed, you will tell the patient, sorry, we are not going to do embryo transfer, right? And that common concept which people have that, probably the culture conditions inside the laboratory are not so good. And that is why when patient is having low AMH and all these things, you should do early day 2, day 3 transfers so that the embryo gets the natural environment of the uterus to grow and all these things. That is all not correct. Why? Because how do you know the endometrial milieu is correct or not to go from day 3 to day 5? How do you know that? In order for you to put an embryo, which is day 3, you should ideally be putting that embryo inside the ampullary part of the fallopian tube. That is where the follicular fluid, the fallopian tube fluid, the HTF, which we call the human tubal fluid, is going to carry the maximum micronutrients. If you are putting an embryo inside the uterus has been optimized by nature for accepting blastocyst, because from the fallopian tube, at the end of the morula stage, at the end of early blastocyst, is when the embryo enters the uterus. So the uterine milieu is graded any which ways by nature for blastocyst. All right. So I personally don't believe in that theory. I again request everyone to follow a single set. Either you do day 3 or you do day 5. Very, very simple. Okay. Don't do sequential. Don't do day 3 also and then put day 5 also. I'm not a big fan of that. Yes, there are people who achieve success rates by doing all that, but I am not a big fan of all that.
So in dual stims, which I know that you do a lot of dual stimulation for, I think, older age group women who opt for self cycles, and since you do only self cycles, so in even in those cases, you would freeze only the blastocyst, is it?
Only blastocyst.
Okay, if they don't make the blastocyst, so
tell them that they have not made the blastocyst. You should go to the patient and show them the embryos on time lapse. See, that is in my laboratory, it happens very commonly. Okay, every month I will go and tell it to 5 to 7 patients that, oh, I'm so sorry, you did not form correct embryos. Correct. See, there should be no shame in that, because patient is going to happily accept it. As long as you are giving the video of the embryo which got arrested, patient will accept it. Okay. So
but that is only if you put it in the time lapse, right? See, if you don't opt to put it in the time lapse, so what do the clinicians do? I mean, do they tell them when they check it on day 5 or day 3 and tell them that?
So to protect the clinicians, actually the government has done a very beautiful embryo record form. That embryo record form actually looks at the monitoring of embryo on a daily basis, which is though not recommended embryologically. But if you fill in that data for the patient, you have a static data. That means at a particular time when you assessed, this was the data which was available. And even that is considered to be as a proof in court of law if the patient takes it. Okay. But my problem is I prefer to put everything in time lapse for most of the patients, because it helps them. It helps the patients. Okay. Rather than helping me, it helps the patient, and the acceptance rate of accepting results is very, very high on time lapse.
So that's the patient satisfaction is better with the time lapse rather than
very much better.
Okay, it doesn't improve the success rate in any ways.
It doesn't improve the success rate in any ways unless you end up annotating the embryos. But annotation of the embryos, see, there are many AI platforms which have come up. Okay, every day we have an AI platform who wants meeting with me because they want to use my time lapse to annotate. Okay, honestly, even if you look at their data, they will help you in predicting which is euploid embryo. They are not going to tell you that this euploid embryo will go and implant. Okay, they will help you in prediction of euploid embryo, honestly.
So you do only one single embryo transfer, or
it depends on what the patient signs, but then SET will be approximately 30% and double embryo transfer will be approximately 70%.
So do you transfer 3 embryos at any given point?
No, never.
So in your lab, do you do plain IVF or is all only ICSI?
We do a combination of both, but 90% is going to be ICSI and 10% will be IVF, madam.
Combination to a single patient, you do half IVF?
Never.
You don't do that?
No.
Yeah, I think this is about it. We'll take the rest of the questions in the groups. Thank you so much. I think it was wonderful to see your lab, especially the time lapse. I think not many of us are exposed to time lapse except for hearing it in the conference. It was very nice to see it practically, especially the embryo which recovered so beautifully. Thank you for your time and effort.
Thank you, madam. Bye. Happy Dashara to everyone.